Right. Well, and that's always been a big concern in my discussions with hospitals, physician productivity, like you brought up, John. I mean, you're taking a physician who owned his own practice, was concerned about, making sure all the bills were paid, that, ensuring that the revenue was coming in, and maximizing revenue. And now they're becoming an employee. How do you keep them incentivized to make sure they are as productive as possible? So I assume, these benchmarks are very significant.
Oh, exactly. And especially, it's interesting to see that when you do put this model together for the hospitals, 9 out of 10 times, years 1 and 2, the hospital's operating in the red, and that's because some of the overhead that they have to allocate to these practices. So that's why it's very important on the hospital side that they make sure they go through each line item on their pro forma and say, okay, what will they look like going forward, and how much of a deficit are we willing to accept in years 1 and 2, and is there a turning point, and when is that turning point?
Right. Well, this is what we're going to do. We're going to take a quick break from our friends at the Chester Company, and we're here with our guests, Helen and John, Helen Hadley, John Koliani. We're talking about hospital acquisition of physician practices. When we get back, we're going to talk about is what's going on now with hospital acquisition of physician practices a rerun of what happened in the 1990s, or is there something different at work here? We'll be back in a minute here on the Healthcare Business Network.
Revitalize the image of your practice with marketing and communication services from the Chester Company. We specialize in helping you communicate effectively with your patients. Whether it's a patient handout that announces a new service or a new website where your patients can conveniently make their own appointments, the Chester Company is here to help you present your practice and its services in the best light possible. Let us show you how. Call for a free, no-obligation consultation. 860-526-9903. 860-526-9903. Call now.
And we're back here again on the Healthcare Business Network. I'm your host, Ron Nyman. We're speaking here with Helen Hadley and John Koliani about hospital acquisition of physician practices. We've been talking about a number of issues regarding the relationship between hospital and physician practices. What do physicians need to start thinking about in regard to being acquired by hospitals, and what do hospitals need to start thinking about? So, Helen and John, I wanted to get to this next question here about what's going on right now, this trend of hospitals to acquire physician practices. Is this just a rerun of what happened, of the hospital acquisitions that were done in the early 1990s, or is there something different at play here this time around?
Ron, I'm seeing 3 distinct differences this time. First, the most critical difference is that physicians do need the help today. They are suffering, as we know, from decreased reimbursements, rising costs, difficulty bringing in and recruiting new physicians, and keeping up with technology, and of course they have the EHR looming over their heads. The second difference is the compensation methodology. Most hospitals will pay the physicians based on RVUs or work RVUs and quality factors today, not gross charges or collections like they did in the 90s. And the third difference is that the terms of the agreements are for 1 to 3 years rather than the 5 to 10 year terms of the past.
So they're going for shorter term contracts here.
Absolutely, and there are still some physicians who are looking to hospitals to employ them for 5 to 10 years, but that's not what we're seeing.
Right. Now, this runs, all of this discussion right now that we've been having, it really runs into the whole question that I'm sure a lot of physicians are asking themselves is the independently owned physician practice still a viable model? And if it is now, will it be so in the future?
I doubt there's going to be a time in the near future when we won't see the private practice model at all. If physicians pay attention to the business of medicine and are willing to accept that a practice is a business, they can be viable. As with any business, it means hard work, providing exceptional service, and controlling expenses. Nothing new there. But in terms of the rerun of the hospital acquisitions, I know John has also seen some things that are different this time around.
Yes, Helen, the biggest difference is there's no goodwill being paid for practices. Hopefully, Ron, you don't get a flurry of emails from physicians, but that's what's going on in the marketplace. You're not seeing that. And it's not that the practices aren't worth anything. The goodwill is in the doctor, and basically the goodwill is being paid in the form of compensation. What I mean by that is you, the physician, will make as much and maybe a little bit more than they are making now. Keep in mind, the hospitals are not buying the practice. They're buying the assets and entering into an appointment contract with the physician. So that's something doctors have to understand. That's different this time around. And the other major reason why there's no goodwill has to do with the Stark regulations. Basically, the hospital could be in violation of Stark if they pay for goodwill or any other intangible with no expectation of income from the transaction, other than which, results because the parties are in a position to generate business for the other party. What I mean by this is if the hospital pays the physician the exact compensation the physician has always made, there's no excess earnings from the practice that the hospital can benefit from. Therefore, there's no expectation of income from the transaction, and that's what's caused, I don't want to call it the buzz, or caused there to be no goodwill. It's really the regulations, and I think physicians forget that they're not buying the practice. They're buying your assets, and they're employing you, the physician. You're the goodwill, and you're going to be compensated for that. And that's the big difference this time around.
So John, what they're looking at is really your balance sheet then, is that correct? As opposed to maybe your income statement, or they're looking at both? Actually,
what you get is you get to keep your accounts receivable. So you'll work on collecting your own accounts receivable. They'll have a valuation done of your hard assets, and that may be $10,000, $20,000, not a lot. And the goodwill piece, there isn't any because you're being employed as a physician, and it's basically factored into your compensation. You make what you make as a physician because of your background, your years of experience, your reputation in the community, your reputation amongst the other doctors in the community. That's your goodwill, and that's the reason they make what they make nowadays. And for the most part, what we're seeing is you're making almost identical the same amount of money that you made in the last 12 months going over to the hospital setting.
So what are you getting paid for when you get acquired then, really, John, at that point?
What are you getting paid for is you.
Right.
They're paying for you. Because there can't be any payments, make it clear, there cannot be any payments or indication that there's payments for referrals, because you, the physician, and the hospital can be violating of Stark and the anti-kickback rules. And I think a lot of physicians forget that. They think the hospital would get in trouble. No, you both can get in trouble.
Sure.
So, there's a lot more, and in Stark, I think it's a phase 3 now with the definition. I mean, it's taken into consideration what happened back in the 1990s, and it's saying this can't be done anymore.
Right. So it must be surprising then to a lot of physicians that you've worked with when you said there is no goodwill here. I mean, that must raise a lot of eyebrows from physician clientele.
Actually, I usually duck, Ron, when I'm speaking, just to make sure nothing's flying at me. But I think the doctors are starting to understand it.
Right.
That this is the way the transactions are. These are the way the deals are being structured right now. And I try to explain to them, listen, it's not that your practice isn't worth anything. It's you that they're employing, and you're the one that's worth something. And some of them understand of it, and actually I think more and more doctors are starting to understand.